We want to talk about successful implementation and folks who are doing the work and be able to see some good modeling of what's working, what's successful. So I have a pretty good superhero team to follow our second team that we had here today. Stacy Andoniadis is a primary care innovation specialist here at CareOregon in the metro area. She spent her career in the physical and specialty behavioral health world, focusing on building systems to sustain high quality care for vulnerable populations. She most recently worked on implementing medication-assisted treatment into primary care clinics. Yay. Dr. Anthony Cheng practices full-spectrum family medicine, including maternity care and hospital medicine, with special interests in addictions, treatment, LGBTQ, health, and health equity. He joined OHSU Family Medicine Residency in 2012 and has progressed to the role of educator, appreciating a deep sense of obligation to provide residents with excellent training opportunities, excited by the innovative spirit of their programs. Please give a warm welcome to Stacy and Anthony.
Thank you. I want the audience to take away from what we say is that this is one of the most rewarding parts of my work as a primary care provider. It's really enjoyable, and the work that I do feels really impactful. And the example that I'll give to illustrate that is a 40-year-old mother of two. She has two kids, like 6 and 4 years old, is married and is an account executive. And her story really illustrates how we can raise the floor of rock bottom and challenging that fail first model. So she was a patient in our practice for about 20 years, had her second child, and was prescribed oxycodone for about 6 weeks while she was post-op from her cesarean section. And unbeknownst to us, for many years struggled with substance use disorder, and ongoing opioid use disorder. And eventually she had some events where she disclosed to us that she was struggling with this problem, and because of our system that Stacy helped develop in our primary care practice, we were able to prescribe Suboxone for her, and she was able to avoid a lot of the downstream effects of substance use disorder that many of our patients do experience. So she is currently stable on Suboxone and is able to maintain her job, really actually never had to take a leave, and her family is doing really well. So that was just a really good example of a success story where we were able to help someone continue on with their life despite their disorder. Another important point about her care is that she actually did have adverse childhood events that weren't discussed initially, or discovered initially, or disclosed initially. And as a result of this MAT program that we have in the engagement with behavioral health, she's now starting to work through some of those issues. And I think her overall health trajectory is going to be positive from that lens as well.
Yeah. And I think, so I have on the slide here some kind of reasons why some of the providers, including Dr. Cheng, started treating in primary care. So he just spoke to the value of treating his patients holistically, so created trust and patience and safety for his patients. Appropriate patients were able to seek treatment in one place. This is a patient that you were describing wasn't necessarily going to go somewhere else to seek treatment, and so she was able to get the treatment she needed in her primary care home. Maybe you could speak a little bit to the inductions piece about how it wasn't as scary as maybe you thought.
Right. I mean, I think we really worry about that when we were first starting this process as providers. And I think our patients know so much about their addiction and have so much experience with adjusting their own doses that the process is very much of a collaboration, and as long as you as a provider set out the parameters of what's safe and acceptable, and invite them into that process, it actually is not very difficult. It just takes time to explain and time to engage, and time to listen about their experience. So I think that was, when I first started prescribing, one of my major concerns, and I think as you go back to your teams of clinicians, explaining that it's not as scary as you'd think is accurate.
Yeah, and I think the other part that we found was that it was worthwhile to prescribe, but also to teach to the fellow clinicians in your clinic and the residents. You get to teach to residents as well about substance use disorder and how to treat in primary care. So that was another part of the reason why the providers began to treat and implement treatment in the primary care setting. So I think I'm gonna go next to the how did this happen? And it happened over the course of several years. And it really started with one or two physicians in the clinic just getting their X waiver because they saw a need in their own panel for patients who had opiate use disorder or complex dependence. So it started with one or two providers, and then from there, as more providers wanted to get their X waiver, and there are now 11 prescribers, or there are 11 people who have their X waiver. They're not at capacity. They're probably not all prescribing, but can at South Waterfront. We knew that we needed more workflows and policies. So we started to kind of standardize the way that this was done in primary care from a team-based care perspective. So I'm just going to go through a couple of these bullets. Chime in as you.
Sure.
Okay.
Yeah.
So we started with creating workflows and policies. So standardizing the timing between intakes and prescribing was a part of that process. We utilize Epic pools and tools. Epic is their EHR that they have at OHSU, Family Medicine in the South Waterfront Clinic, and maybe all now, for population patient management and DEA requirements. We use team-based care and leverage current staff interest and abilities. So they have behavioral health consultants, they have behavioral health teams, but we also talk to the other staff, the patient access staff, the referral coordinators, to see who is interested in this work and who could help support it.
Yeah, and the result of all of that work is that now when we have a new patient that needs to be induced, we basically just say the word and there's a reflex that everybody has and everybody knows what they need to do. And so from a busy clinician standpoint, it's much less disruptive with this workflow in place and allows me to keep seeing my patients and stay on time and still do this really important work. So I think one of my perceptions going into the process was that it was going to be a really high intensity service, which it does require more because these patients need more, but it doesn't have to be as disruptive when you have systems and teams that all know what their role is. It's kind of like from as our paramedics know, when you're running a resuscitation, if everybody knows what their role is and has practice, it can go much smoother. So that's kind of how we've treated it.
Yeah, thank you. So Dr. Cheng spoke to kind of the behavioral health coordination. So the behavioral health team can help coordinate referrals and resources. They can help transition patients to specialty behavioral health when it's needed, when the patient says, I need more, when the provider says, I think you might need more in addition to the medication. And then really intentional about allocating staff time for that, and so that we could respond in the moment when patients needed care. Let's see here. So we implemented multidisciplinary team meetings. So primary care, support staff, behavioral health team all came together to review patient care, complex patients, best practices and workflows, just like you do with many other chronic conditions and diseases. We had the same aspect. So we could talk about complex patients, but also talk about best practices. And I think that was really helpful, and especially in the beginning when we were all kind of getting on the same page about like why are we treating our patients? What's the value in doing this in primary care, and how do we make it as safe and sustainable for our clinicians and our patients? And then we created and utilized our electronic medical record to make the actual prescribing and the behavioral health consultant work and behavioral health resource work as efficient and effective as possible. And so what that really meant was just creating the smart sets where you could be in one spot in your electronic record to treat a patient. So you could go through their COW score, you could order labs, their UDS. COW score is the for those, it's the detox, kind of knowing where someone is in withdrawal. Sorry, not detox, withdrawal. You could do your referrals to behavioral health specialty, and you could provide in the moment brief interventions, which a lot of primary care clinics were encouraging integrated behavioral health as part of this care, part of patient care overall. So the behavioral health team was able to access the resources they needed in the moment.
Yeah, so a couple of things to add with those clinician or interdisciplinary meetings that we started having in the clinic. It didn't feel like just another meeting, because I think from a provider standpoint, there's this sort of sense of loss around the loss of the water cooler. Like, we're all so busy. There used to be a doctor's lounge. There used to be a place where you just hung out and chatted about things, and things are so busy now that we've lost that opportunity. Having meetings or opportunities as an integrated team to talk about difficult patients, specifically around the MAT program we have, has sort of reinvigorated that a little bit, and brings a little bit more joy into our practice. So it's actually been really good from a physician wellness and provider wellness standpoint.
And I heard you just speak to the, in the beginning you said that you enjoy taking care of this patient population. So these are the tools that you can kind of implement in your clinic to help with that enjoyment, because it does get hard at times.
Yeah, hard as in challenging, but not hard as in unpleasant necessarily or
Unpleasant.
bad. Like, so that's I think what we really like, the work that we like. That's what brings us here. It's not because we want to have an easy day. It's because we want to feel like our work matters, and so that's why we do this.
So I'm gonna switch now to the next slide. So I'm going to talk a little bit about what we would suggest if you were thinking about how to implement in primary care. So really with the goal that medication comes first, and with some basic supports, you can do this in a primary care office. And those basic supports do mean like integrated behavioral health and using your electronic record and having a referral process as needed. Go ahead.
Sure. So I think whenever we approach a change in the clinical system, it's really important to involve everybody from beginning to end. And so it was really important to involve the entire clinic leadership team that included administrators, front office, back office, providers, other support staff. And so that really helped us develop a workflow that worked. And of course, there are some hiccups and false starts at the beginning, but we were able to work through those, and it was pretty effective. And then I think having those opportunities for people to discuss their fears and concerns about the process and to participate was also important, because I think everyone's level of confidence really did improve significantly over time. And then the standardization was also really helpful, just from that sort of first responder mentality of like, okay, this is the condition, this is the situation, we're going to do this process. That all made it easier, but then there's obviously room for discretion to deviate from that protocol when it's appropriate.
And I guess the pieces that I would add are the educational, making sure that you're giving your clinicians and your behavioral health staff and the whole clinic just the educational opportunities that they need to address fears maybe related to the patient population, maybe address fears of the inductions, just so there's a space to continuously gain education to feel confident. And then I would really say, thinking through with your clinic team, your champion team, your staff, like what is important and what tools do we need to prescribe to this population? What do we need before we start prescribing to make sure that this is an effective and safe process for our providers and our patients?
Yeah. So then another story that I'll share is meant to illustrate how this type of work can sometimes address our feeling that we're spinning our wheels. So I think a lot of us have experienced patients where we're saying the same things over and over again. They're not changing. What is missing? There's something missing from this care. So I have a patient who is in his late 20s. He was unemployed, depressed, had some cluster B traits, so it was really difficult to work with. And he was really fixated on this chronic inguinal pain that happened to start after he had an inguinal repair surgery, and had been to see like 15 different specialists in multiple states to try to figure out where this pain was coming from. And it was really frustrating because as a provider, I didn't feel like I could help him with that problem. at some point, he found out that we offered MAT and disclosed to me that he had been using opioids illicitly ever since he had been the primary caregiver for his grandmother who was on hospice and had access to morphine. And I noticed a really stark shift in the conversations that we had once we put him on, he started MAT. His pain continued in the inguinal area, but he felt less distress around it, and there was an entire, and I don't need to tell you guys this, but there's an entire like half of his brain that had been constantly occupied with the addiction, and just quieting that allowed us to feel like we were able to work on the other important parts of his healthcare. We were able to start working on his depression, and he became much less fixated on the chronic pain, and that was the first time I really felt like we were able to do anything positive for him, other than just support and avoid unnecessary interventions. So it feels like this type of a program can make our work as primary care clinicians more impactful. And it's so powerful to the extent that we have our 11 clinicians that have X numbers. We all love doing this work for the patients that are in our practice and the disorders that emerge from our own practice. And we're really ready to start shifting towards recruiting patients from other practices that aren't established with our practice to maybe start doing this work for new patients. So we have a question in the audience from Dr. Azevedo.
How did you fund the additional needed behavioral health support?
I can speak to that. We at South Waterfront, we used what we had. So we had some behavioral health staff. We had a behavioral health consultant. We had some students and a resource specialist who were wanting to treat what they could within the integrated behavioral health model. So we used brief interventions. And then in terms of like developing the program and all those other pieces that you saw on the screen, that was extra time that we worked with some of the specific like key faculty members. So we didn't add any positions. We used interest from staff in the clinic and encouraged development of core competencies for the behavioral health staff. Great question, and I think that is something we have to address immediately, how to fund this.
Because and I think right now it's very much driven by providers or the clinic system deciding that from a health equity standpoint, this is important. These patients need extra care, and they deserve extra care, and so we'll fund these extra positions. So that's how it is now.
Do we need to?
What I would just suggest, if I can, real quick, is first of all, guys, would you give these two a huge round of applause for their work?